everybody's here then. Yes. Well, we'll start the meeting then. All right. Membership of the committee. Do we have any apologies for absence today? Oh, okay. Thank you. Minutes of previous meeting. Do we agree the minutes of the previous meeting? Yes, if everybody can indicate. Yeah. Thank you. Thanks. Are there any declarations of interest that we need to account for? No. Okay, thank you. If members of the committee can raise your hand either virtually or by raising your hand, that would be great. Thank you if you wish to speak. All items are in public. Do we have any deputations or petitions today, Mike?
No, Chair.
Thank you. And we've not been notified of any public questions. So we turn to the West Yorkshire Urgent Care Review. Can the representatives from the ICB, is it Tessa or John that's going to be talking about this item? Are representatives from the ICB at the meeting? Is somebody trying to speak and has got been muted?
So myself and Hayden are from the ICB.
And who's speaking on the West Yorkshire Urgent Care Service Review? Rachel?
Sorry, Councillor Major, I'm not speaking on that item. I was just saying that I'm here representing Public Health for the ICB for the dental item.
Thank you. Hayden, are you starting this item off?
No, Chair, I was going to say, so Jane and I are here for the dental discussion later. If it's helpful, I can send John Barnaby a quick Teams message and see what's going on there.
Okay, so members of the committee, would you be okay if we move to the dental item while we sort out the West Yorkshire Urgent Services Review? Okay. All right, so we'll move then to the dental item then. So Hayden, are you here for the dental item?
Yes, Chair, I am, and I think you probably noted, but Ian Holmes is also going to be here, but sends his apologies today. So what I was thinking is I'll spend 10 minutes or so going through the sort of contents of the paper, providing a bit of a summary. And we've got some colleagues like Peter, Joe and Jane here as well that are from the profession that may want to share some reflection on what I say in their own too, and then get into discussion. So I'll spend a short time and spend most of the time on discussion. And there are some sort of key context points really before we delve into the rest of what the paper says on the progress we've been making and the work that we still want to do. The key points of those really are on the 1st of April, the ICB became the Commissioner of Dental Services, inheriting commissioning responsibility from NHS England. And we were really keen to become the Commissioner. We both had an ambition that was one of improving services and trying to grapple with the challenges we know we've got in dental services, and also one of looking at how we could integrate dental services into the wider offers that we've got as a health and care system to improve the experience of patients. Then on the 16th of May, so about 6 weeks later, we took a paper to our ICB board meeting in public that set out our ambition for dental services, and all the recommendations in that paper were supported in full. And I'll come back to them in more detail, but to summarise, those recommendations include maximising use of the dental budget, enhancing flexible commissioning, developing a dental workforce plan, improving the relationship between ourselves as the commissioners and public health, with a real emphasis on data and a life course approach to prevention, water fluoridation, and increasing the capacity of the dental team through recruitment. There are some fundamental challenges, as I'm sure everyone on this call is aware, with dental services and oral health. There is, I think it's fair to say, a high level of dissatisfaction amongst members of the public and frustration in their inability to access services that we're taking really seriously and working really hard on. There's a Health Watch report attached to the paper as an appendix. I think it's Appendix 1. That's got some really harrowing stories and quotes that no doubt you'll get from people on a daily basis about their experience of dental services. We also, again, in the paper, receive a pretty sustained level of complaints around access to dental care and things of that nature, which, again, paint the picture of the challenges, but also we're committed to taking really seriously and trying to build that into how we also respond. So if we're seeing themes in complaints, how are we designing services in a way that addresses those things as well? We've fundamentally got, I would say, an understaffed and a worn down profession, both as a result of the pandemic that was difficult for absolutely everybody, but years of challenges within the dental system as well. We've got a small commissioning team, as I alluded to, and so the capacity to do the work and the transformation is limited, and we've invested in that and recruited as well, which I'll come back to. The national contract is a key point of contention, and my dental colleagues here will be able to speak far more eloquently about that than I can, but it's effectively not necessarily what the profession need to innovate. It's not been reformed enough since 2006, and reforms have perhaps not gone far enough. And the UDA system fundamentally disincentivises activity in the places that we'd most want it. Again, we can come back to that slightly later on. And then the data picture is slightly bleak from what we know, but also slightly patchy. So there's some opportunities, again, alluded to in the paper, to improve. So even though, having said all of that context, those challenges, we do think there are still things that we can do as an ICB, which is what the paper sets out, and I'll provide a brief summary of through an ambitious and transformative and a proportionate calculated risk approach in doing that our board supported. So since we took that paper, then what we've been prioritising mostly is immediate investment to deliver benefit in year to patients and the profession, spending an investment plan of £6.5 million. That £6.5 million investment plan is made up of money that we've projected will be returned to us from under delivery against contracted activity within the profession. So we're almost reinvesting that at risk up front. And we believe we'll get that back and are fairly confident of that. And so we've invested that in several areas to make a difference in year for people. And we've designed that plan with the profession and taking it through our local dental network, which includes a host of dental professionals and Health Watch representation. There's a draw out a few points of that plan then to give you a flavour. Investment in the urgent dental care system through a sessional model. Now, this effectively ensures that anybody, wherever they are in West Yorkshire, can call 111 and they can get access to an urgent dental appointment if that's clinically necessary. These appointments run through general dental practitioners and is on what we call a sessional arrangement. We're creating capacity for people to access care when they most need it, and we know that if general access is poor, clearly people are more likely to have a more urgent need as well. It's worth saying that there's more we can do there, and we're actively considering that too. As well as those sort of blanket and more universal offers, we're looking at how we can target schemes as well for particular population groups where we know access is the worst, oral health is the worst. So a really good example, I suppose, would be the homeless work that had been running in Leeds for some time, and we've expanded right across West Yorkshire. Now, that model effectively sees general dental practices work with voluntary sector organisations to support the population group they're working with, homeless people in this example, to get to the dentist, to be seen. And when that course of treatment is completed, that person's then offered the opportunity to join the dentist's regular books, if you will. So that's for the homeless. We've already adapted that for refugees and asylum seekers in our region, and looking at how we roll that out across the 5 localities in West Yorkshire. And I suppose what's also worth saying on that is it's fundamentally about how we use our resource to create access that's targeted towards tackling inequality. So there's a transferability to that model there. Also really committed as well to making these changes across the breadth of the dental pathway. So community dental services is a great example where we've invested to both increase staffing capacity in the short term and exploring some really exciting schemes like the Level 2 paediatric scheme. The scheme effectively trains general dental practitioners to become Level 2 paediatric trained, and they can deliver treatments in their sort of high street practice, if you will, to patients that would ordinarily be waiting on a community dental service hospital style waiting list for quite some time. So it enables quicker treatment of patients, hopefully better experience for those patients close to home, but also it enables those waiting on that community dental service waiting list to hopefully be seen a bit quicker because we're rationalising that list in a different way. And the final area I suppose to highlight of that investment is the investments we're making in prevention. So we know there's a real acuity to the dental access problems, and we need to address those now in year. We need to continue doing that. But we also need to focus on stemming that demand. And I think prevention is inherently valuable in itself. But clearly, if we are doing more to support people to keep their teeth and oral health well, we may be able to stem that flow. So we're investing in a bunch of areas, including through local authorities. Most of the local authority investments focus on things like supervised toothbrushing, working with children and education settings. And we're also working really closely with the University of Leeds, and I'm sure Peter could say a bit more about later on a number of schemes too. In terms of, I suppose, the non-immediate, non-financial progress, we're also trying to grapple with that and sort of straddle a boundary of immediate intervention and sort of the mid to long term, really. And in the mid camp, we've engaged with flexible commissioning already, and there's a group that's functioning across the Yorkshire and Humber region. And flexible commissioning, for colleagues' benefit, is a scheme whereby you substitute a proportion of a general dental practice's contract, and they deliver that activity differently away from the normal contract that is perhaps one of our challenges. The ICB ambition is to increase the number of practices engaged in that scheme and to increase the percentage substitution to up to 25%. And so we're well on our way to doing that. I'll be hoping that we are running that improved scheme of a version that we've already got into the next financial year. There's also the dental workforce plan that we're grappling with that has 5 areas of focus. Those are understanding the workforce, so through surveys and things of that nature, enabling workforce training and development in line with our intentions for commissioning and services, the idea of centres for dental development, which I'll come back to a little bit later on, a focus on international recruitment as and where that's necessary, and a real emphasis on recruitment, retention and development that meets patients' needs both now, but also patients' needs tomorrow and in the future too. Again, as I've said, discussions around water fluoridation, and we've got a broad consensus across the Yorkshire and Humber, because clearly water flows that way. We couldn't just fluoridate water in West Yorkshire. That would be quite challenging. So we've got consensus across the Yorkshire and Humber, and we've taken that through our ICB and our public partnership board with councils present too, and really broad support for that. And we're trying to learn from regions that are sort of going ahead with this already, particularly in the North East and North Cumbria region, and working with the Department of Health and Social Care on effectively system readiness for when the time is right for that. And that, as I'm sure many of you are aware and appreciate, is the single most significant thing we could do to make a difference and improvement to oral health of all the people living within West Yorkshire. We're also working with CDS providers on things, Community Dental Services, sorry for the acronym, with those providers on things beyond immediate investment, and they're coming together to collaborate on where they might be able to help each other. So using their resources more collaboratively rather than as individual providers. Really great discussions, working really closely those providers with acute trusts on things like access to theatre space. There's a real challenge there. It's a really good piece of work, and also looking at data and future models of care that we might deliver that I'll touch on in a few moments too. We've had some really good discussions and are grappling with the epidemiology survey. So the epidemiology survey is a national survey programme that runs and is administered and contracted through the local authorities now. Really important set of data that effectively monitors the oral health of our population. It is important to guide the interventions we are making, but also to assess the impact we're making too. At present, 2 of 5 of our places in West Yorkshire deliver that survey. There are some challenges that we're trying to work through, and we've been in the space of identifying the problems and the solutions there. I don't think I could emphasise enough how important that data is, and hopefully colleagues agree, and trying to come towards a solution on that feels really important. We've really focused on building relationships too, and again, I think that's absolutely underscores all the progress we've made. I could sit at home and design a plan, but if I didn't do it with the professionals that know what they're talking about, that have experience, it perhaps wouldn't go very far. We've really invested in those relationships, and I hope my colleagues on the call today will attest to. And we're also investing in relationships with people and the public, really committed to these conversations. We've also set up a dental patient reference group where we hear from people the challenges, but we also empower them to think about solutions, and that feels really important and positive. And we've recruited to the team, so we've recruited 3 or 4 posts now to the dental commissioning team that will add the capacity we need to deliver the transformative programme that we've just outlined. So final points then, I suppose. We've made that progress, as you can see, and we're absolutely committed to delivering over multiple time horizons that the progress that we're making now, but also setting ourselves up for tomorrow and planning for what we could do beyond that into the months and years that come. So I think, most importantly, we absolutely need to continue delivering what we are, and we're committed to that, both the additional investment, work on flexible commission, the work on the workforce plan as examples. We also, I think, need to get ahead of the curve and absolutely committed to doing that. So the investment we're making is absolutely important and will make a difference. So we're maximising use of the dental budget. We also need to be in the business of trying to stop the problem of the clawback coming in. And that means we need to work with practices on proactive solutions and policy positions. But there are some solutions that sit beyond our immediate gift, perhaps nationally there, that I'll finish with in a few moments. We're engaging in planning for future financial years. We developed our investment plan this year and agreed it in July, and we're delivering it really well, and it's making a great difference now. If we can do that now or in the coming months for next year, we'll clearly improve the difference we can make, and that's the space we're in. We're absolutely starting to delve deeper into how we transform the care that is delivered to. I'll give you two examples. Working with community dental services, we're looking at how we could effectively reform that service that exists. There are some challenges with things like service specifications, current funding envelopes, and we're committed to giving those providers the license to design what they think will be a good solution and a good model, and having that collaborative conversation. And we'll be doing that over the next 1.5 to 2 years or so. We're also looking at brand new things that we can invest into. So the idea of centres of dental development that I touched on earlier. Now, these are a few things to note about these, I suppose. They fundamentally align the training and development of staff with service delivery. And at the moment, that's a slight challenge. There's a retention problem in dentistry, and that could help us improve that. It could help us improve rates of access by effectively creating additional services for patients to access. But we could also tailor those services towards particular population groups, looking at simple things like where we put those services, putting it in some of our areas of highest need. So we're in that space of thinking about how we do that, and that will take some time, but we're absolutely committed. And final points on the things that I think the space we're getting into. We need to develop a way of measuring the impact we're making. So I think I've played to the challenges in data. It's really important, and we're committed to doing that through our joint forward plan refresh process as well. I think there's more we can do to align with public health teams. We're doing that really well already, and funding is a good show of how we're doing that. But I think clearly oral health and prevention and promotion and delivery of dental services and access to those services are two sides of the same coin. And we need to be working really hard on that relationship to ensure we're working in tandem, and we want to continue engaging nationally and influencing that discourse where we can. So, summarise. What I hope you can see is that the volume of progress and the challenges that we're dealing with, and a real willingness to get to grips with those challenges. I really value your thoughts and reflections, and being a critical friend, I suppose, on the progress we have been making. And specifically, I suppose, to highlight a few areas, thinking particularly about the oversight capacity of members of this group and the role that you have as elected officials as well. Your thoughts and support and guidance on things like how we champion and push our vision locally, of acknowledging that there are challenges, but acknowledging that we're doing lots to try and overcome them, and that there are some national contextual factors here as well, things around contract reform, workforce planning and water fluoridation that it'd be good if we are aligned on, and we can influence for the people of West Yorkshire. Improving the link with public health teams is a particular area of importance. Supporting the engagement that we have with local people. I've no doubt that you hear from people daily, probably, about the challenges in access to dentistry, and how we support that flow of information and a bi-directional conversation is really important, and something really welcome. And the utilisation of the epidemiology survey. So I'll stop there, Chair. I'm not sure if my dental colleagues have anything to add. Thank you.
Okay. Rachel, do you want to say anything from a public health perspective?
I think if it's all right, Chair, I'll probably wait for the discussion, but I would probably just ask, in terms of colleagues on the call, to think about access, both not in relation to distance, but also in terms of times of appointments, because we do know from our population that people that have multiple shift patterns, etc., it's the access, both from a time and a distance perspective, particularly given the cost of living situation and the amount of people in poverty. So all of that will mean that people will struggle to access. Thank you, Chair.
Thank you. So I'll open it up for questions then. Some members of the committee who would like to ask some questions. Councillor Scopes from Leeds. Yeah.
Thank you very much, Councillor Chair. Thanks for coming to Leeds, Hayden. You're probably sick of hearing me ask you questions, but just a few questions, if that's okay. So the first one is around the dental framework contract, and I just want to understand, I think it's worth talking a little bit about who has what power. So clearly some commissioning powers come to the ICB, but I think they're still challenging around the framework contract, which I guess is really frustrating because then your hands are tied, so you don't really have the power that you need. So I think something around what's your power and what your power isn't, I think it's really important to understand. And I think that's really frustrating for us in West Yorkshire. I think probably for you as well. The second question is around capacity for local areas and where they're low. And I know we talked about this, I don't remember if it's last week or the week before, and somehow having some hotspots around. I know you're going to do some work for Leeds, but I think other areas would be interested in knowing where the hotspots are for not high access. And I guess that links back to the previous point about the framework. How do you get more services in the areas that we need it? And I know my colleague Councillor Hutchinson was mentioning this in our pre-call being a real issue in some of our deprived areas, which I think is really important. And then the third thing is just around recommendation 3. So I grew up in Milton Keynes, you can tell by my accent, and we had fluoride in our water, and that I've never had any problem with it. I guess I've come to this conversation with no, I guess, academic or intellectual understanding of the pros and cons of it. And I guess I would be keen to make a call one way or the other, but at the moment I don't feel like we've got the data or the information to do that, if that makes sense. And I'm only one member, so obviously the board can make a different decision, but I think there's something around upping our education on issues like that. So I guess the recommendation 3 is sort of talks about support and guidance. Very happy to do that, but I need more medical robust research and data to make a judgment on that sort of thing. So those are my 3. Thanks.
Okay, thank you, Councillor Scopes. Hayden, do you want to come back, or Jane?
I'm happy to come back and on the final point, in fact on 2 of the points, perhaps if I do open it to Jane or Joe or Peter. So to cover on the contract, from what I know, Councillor Scopes, you're right, there are certain things within our gift, certain things not. Contract reform fundamentally will sit at the national level, and we need political appetite to be able to do that, and we need the space to be able to do that, and clearly we would want to be part of influencing that process, and would our dental friends would want to work with the BDA and people of that nature as well. The bit that's within our gift for now is making it work as best we can. So I talked about flexible commissioning. What we've got the opportunity there is to fundamentally improve 25% of the contract. Now, it's not all of it, but it will make a difference. So that's the part within our gift, and colleagues may have, Joe or Jane or others may have more to say about the contract. On the capacity for local areas and heat maps, so for colleagues' benefit, we went to the Leeds group that Councillor Scopes chairs and raised this exact question, and we have some data that we would call a heat map that shows effectively your dark spots of access, and we can share that area by area, and we're absolutely committed to using that to additional investment. So we talked about the urgent access scheme. We're committed to investing a pot of money to enhance that. If we know an area's got particular dark spots, we'll be looking at what we can do there to support practices to provide those services. If that data's of interest to the group, we can source, break it down and share in time. And the final point I was going to make was on water fluoridation, which is where I will absolutely rely on my experts, because like you, Councillor Scopes, I don't fully understand the scientific knowledge, but what I do get a sense of is that the evidence is pretty clear on the pro of water fluoridation. But I'll invite other colleagues on that point. Thank you, Chair.
Okay, Jane, did you want to come in on these points?
Yes, if I can. In terms of contract reform, the profession has been campaigning for that for a long time, and with the move to the ICB, although contract reform is still on the national agenda, it's not moving fast enough. But the initiatives that the ICB have put in place, particularly the 25% move towards flexible commissioning, will make a big impact locally. So we're not waiting for national reform anymore, because it's dragged on and on and on for years and got nowhere. But we can make a real difference locally. The increase of the amount of flexible commissioning to 25% gives us the opportunity to create sessions for all sorts of disadvantaged groups, not just the homeless, but also asylum seekers, children, and other disadvantaged groups, gypsy travellers, all the disadvantaged groups. And also we can target to reduce inequalities in the best way by targeting the areas that need services most. In terms of fluoride, there is a wealth of scientific data out there. We've been looking at fluoride in the water for 40 years or more, and there is absolutely no evidence that fluoride in the water is harmful, and there is an absolute enormous pile of data on it, so it's not difficult to access at all.
Can I just come back, Chair?
Yes, of course,
Yeah,
yes.
yeah, just 2 quick points. Can I suggest we make an extra recommendation then around asking the government to review the national contract framework in consultation with the ICBs around the country? I think that would be something that hopefully would be widely supported by the ICB here. I think the point you make, Jane, is that there's lots of data, but I guess we are lay scrutiny people, and so I guess I totally believe there's a ton of data. Don't hear what I'm not saying. Totally believe it. I guess what I'm saying is, as a scrutiny member, I'm asking for the public health team to bring me some of that data, just as they bring me data when we're talking about almost anything that's public health related. Yeah. We don't claim to be the experts, and I could Google a whole bunch of reports. Again, I grew up with fluoride water. I almost certainly 100% behind it. It's just in my role as a scrutiny board chair, I guess there's an element of where I need to take advice from the public health officials and them to draw out certain data for me. And so I think what I'm asking is for a little hand-holding, not any disagreeing, just to be clear. Thank you.
Okay, all right, thank you. Councillor Hutchinson.
Yeah, I fully endorse what Councillor Scopes has just been saying about the data being, the evidence being put before us rather than us having to go and find it for fluoridation. So that's something that we could hopefully look to going forward. I was really impressed by the paper that was taken to the Integrated Care Board in May, the sort of energy and sense of direction that there was expressed in it, and I hope that gets carried forwards. But one of the things I noticed, and Hayden had referred to it, is that Calderdale has been unable to secure a provider for oral health needs assessment, and is not alone in that. Has that been resolved yet, or is there anything that can be done at Integrated Care Board level to actually, I'm not quite sure why they've not been able to secure a provider, whether they're not able to fund it sufficiently. Is this some, but without that data, we're really in the dark. So that was one question I had. Another one is as we know with primary care in medical services, the areas that most need them are the areas that are least well provided for by in general practice and in dentistry as well, that there are these and they coincide with the areas of maximum deprivation, maximum need. What exactly are the tools that are available to the Integrated Care Board to actually boost that provision? You've said that that you're trying to work with it, but I'm not quite clear exactly what you're doing in that respect and what powers you have in that respect. And my third question was that oral cancers have a terribly high mortality rate. You know, the figures that were quoted from last year's rapid review of health needs assessments suggests that 1 in 3 people who get oral cancers die from them, and yet pre-malignant changes are fairly easily detected by a general oral examination by somebody who knows what they're looking for. So, but there's very little attention seems to be given to the early detection and treatment of malignant and pre-malignant oral cancers in the report that was taken to the Integrated Care Board in May. And is this something that really demands greater emphasis? I mean, the rates are highest in people who smoke and drink alcohol to excess, but you know, these pre-malignant changes are visible just on clinical examination.
Okay, thank you. So, Hayden, who wants to come in on this? I've got Jane and Joe that have got their hands up. Who's coming in on this one?
Can I start the response, Chair, and hand over to Jane and Joe when it gets too clinical for me? Thank you. Thank you, Councillor Hutchinson, as well for the questions and the kind words about being impressed. That energy is absolutely retained, and what we're absolutely trying to take forwards in how we're delivering. In terms of your question on the epidemiology survey provision in Calderdale, so I can't profess to know the ins and outs of the challenges in Calderdale. What I do know that the challenges broadly are, firstly, not unique to Calderdale, not unique to West Yorkshire. They are seen nationally. They will include things like resource for the surveys. They'll also include things like the capacity of staff to go out and deliver the survey, which is a particular challenge when we're trying to deliver lots of services, and more challenges, I'm sure. There's not an immediate resolution for what I understand in the areas that don't have the survey provision. As I said, we've got 2 of 5 that do, which is good, but clearly we'd like 5 of 5 to be delivering that survey. And we are working really closely with everyone to be able to do that, bringing together the local authorities and the ICB, recognising the importance of that data. And the space we're in at the moment is thinking about, firstly, what's the immediate solution? Is there anything we can do to get a good grip on the data? But long term, what's the solution? Because it suggests something's perhaps not working with the model. And we're also working really closely with dental public health colleagues, and the provider of the service nationally is known by an acronym BASCOD. I'm not quite sure what the acronym stands for, but we are working with them as best we can to understand the art of the possible to improve that. So hopefully in future we'll have a better position on that. Fundamentally agree as well. You're going to come back in there. Okay, I thought you were going to comment there, Councillor Hutchinson. Fundamentally agree with your point about most need and having the least, and that brings you sort of back to Councillor Scope's point about the heat maps and how we use the evidence we have got to direct investment. And I think your question specifically was, what tools do we have? The tools we have for now are the additional investment that we're making, that we're targeting as best we can, and the flexible commissioning that's currently running but will improve into the next financial year when we've finished that model. That can make a significant difference. I think Jane's outlined. I suppose the other thing of note on that is, as I said, the data picture is probably both patchy and bleak, and the space we want to be in is both improving that data, but also knowing that what the data will show us is what any other data set shows us about deprivation and health outcomes and access to services, and therefore we're acting on best intelligence to direct the investment that we can now whilst trying to improve that. On oral cancer mortality, I will mostly leave this to my clinical friends, but the point I was going to make is one of the key opportunities we have got is to better integrate services here, and we know that the risk factors for problems like that are often shared with others, and we try our best. And again, perhaps one of our dentists could comment on this, to align dentistry with things like smoking cessation services and things of that nature. So I'll pause there, Chair. Thank you.
Okay, so Joe or Jane, which one of you wants to come in on this?
Can I just come in on the oral cancer part? First of all, an oral cancer check is an integral part of any examination. So as long as patients are getting to the dentist and getting their examinations, they will be screened for oral cancer. So the problem can arise in that if patients have got difficulty accessing a GDP, then they're not getting that screening. So long as the patient does have access to a dentist, they will be screened, and we have a pilot for the 2-week wait patients who have suspected lesions, and we are going to have a photograph of the lesion sent to the Leeds Dental Hospital so that patients can be screened more efficiently. So we have that pilot, which will be starting soon. And we have also, as an LDN, developed a safe discharge pathway. So for patients that have had head and neck cancer treatment, we have a number of volunteer practices in Leeds and across West Yorkshire who will accept the patients post-treatment and look after them going forward. So oral cancer is high on our agenda.
Okay, thank you. I think the point is if they can get a dentist appointment, I think that's where we're coming from. Yes.
Absolutely.
Yeah.
And also the fact that people who've lost their teeth don't seem to realise that there's still a purpose in having an oral examination, even if they don't have any teeth left.
Yes. That's true. Yes.
Yeah. Joe, did you want to come in at all?
Yeah, just to reiterate that, as Jane says, it's an integral part of the dental examination, and really the difficulties in access for the oral cancer screening was exacerbated by the lockdown and the COVID period. But ultimately, it's the dental contract that is the issue here, because it only pays for 52% of the population to be seen. If everybody wanted to see a dentist tomorrow, there just wouldn't be enough units of dental activity there to pay for that. And that's a central government issue. But certainly the work that's been done by the ACB in order to improve access through the flexible commissioning and the urgent care access sessions will open some doors for people who haven't seen a dentist for a long time, and while they're being assessed for their urgent abscess or broken tooth on the urgent care session, they will be assessed for oral cancer. So that is an improvement that's been developed locally and should be hopefully addressed with a new contract. But Central NHS England do not have any intentions to fundamentally change the dental contract that we have, and they say that it's not the time is not financially conducive to do so. We got this last week from the director responsible for dentistry at NHS England. But just coming back to the water fluoridation, there is a vast scope of evidence out there in support of water fluoridation, and dental public health and local authority public health do support this. And I have experience of making a presentation to Wakefield Council with regards to reviewing the ability for them to approve fluoridation in the area, but they didn't find that the evidence was strong enough. Now, I find that very, very difficult to believe, and I think it's possibly an election issue that individual councillors may be concerned about this. So I welcome the fact that the question of water fluoridation is now to be taken centrally on a national basis. And Rachel mentioned at the top of the meeting about opening hours. We're talking about a workforce issue, and it is very difficult to attract younger dentists into working in the NHS at the moment, and there is work going on locally for workforce issues in order to try and retain dentists. But you mentioned about the opening hours, and one of the issues that I found in trying to recruit a dentist is that they want to come and work 9 to 5. Our practice is open 9 till 6 every day, with 2 late nights on open till 7 o'clock. But they find that that's too onerous for them to work. So we've got a lot of work to do in order to convince younger dentists to commit to to providing the service that we have up to now. So hopefully I've answered a couple of the questions.
Okay, thank you. I just a quick point that we are here as scrutiny members, and so we do leave our politics at the door, and we are here as scrutiny members. Okay, but as you've mentioned, Wakefield, I'll bring Councillor Rhodes in with Councillor Bragborough's permission. I'll bring Councillor Rhodes in to address this particular item. Thank you, Councillor Rhodes.
Okay, thank you, Chair. First of all, may I declare an interest, because it's good to see you, Joe. I am actually a patient at Joe's St. Michael's practice here in Wakefield. And secondly, to address the last issue of when you did and your colleagues attend Wakefield Scrutiny, there was a strong discussion there. I'm not going to go back through the minutes on it, but I know it's minuted. And at that particular time, I believe the outcome was that enough information at that particular time, which is well over 2 or 3 years ago, maybe even more, and we'd welcome any further information on that particular topic before making any decision. And fully endorsing the comments that have been made already. And I think it's important for colleagues, if we just deal with the fluoridation now, it's important for colleagues actually to be aware, and I'm sure they all are in terms of their own input into their own scrutiny, that this is a top-up of natural fluoridation that's out there already. It isn't as though there's none available, but it's a top-up to the natural fluoridation in terms of prevention and tooth decay, etc. And one of the last issues that Joe did touch on, which is important, and we've had a discussion of scrutiny about, and I don't think we're on our own, is the issue of young dentists. And yes, it is important, because I think everybody wants to look at their own family life situation, but in the prevention and provision of health agenda in general, it is seen in some areas as an obstruction and impediment to the issue of gaining access to that part of the health provision of an individual, as opposed to where in other parts of the health provision agenda as a whole, it's more open and available. And having said that, in response to Joe, I'll go back on some issues that have already been touched on, if I may, Chair. Supporting our Leeds colleague in the data that's out there that is allegedly up to date, and more information about, and hotspots, etc. I'd like to ask Hayden and the colleagues here representing the this particular item today. The ICB took it over in April, and you've had some money sent back to you that you're using as investment. I mean, this may be just a drop in the ocean, but at least you're using it. Each authority is represented on the ICB board. But what I want to know from Hayden and the public health agenda is, in your provision of information that goes to the ICB from what we're calling local place now, do you have information that can be broken down to each authority at its level? And in that data, do you have the hotspots where the local scrutiny boards can actually keep an eye on it? That's the first one. On fluoridation, Hayden, forgive me, I think you said that you'd been meeting with various people from local authorities, etc. And obviously, I'm sure all of us around the table will be following that at home in our own agenda, because I'd like to know what the conversation and what the vision was that you actually had a discussion about. The flexible commissioning is a way forward, and I know you're conscious of time and you race through it all, but in terms of the information surrounding and the outcomes, I think that is something that we would want to have an overview on. And I will be making a recommendation of my own to add it to our Leeds colleague is that from an overview point of view, I think it's very important on this particular item that from our either place within our local authority or from the ICB, we as an overview committee would like to have a monthly or 6 weekly update on the progress that's identified in your vision and plans for the future. It does disturb me when I hear you say, Hayden, because I'm coming back to the local plans again, local place, and I believe you described them as data patchy and bleak. I'd like an understanding of that, and I'm sure every authority would, being as that's a statement that's been made today, because surely that's got to coincide with the data that you've got in terms of hotspots. If it doesn't, then we've got two issues. We've got hotspots and we've got patchy and bleak. And I'd like to know which has the priority within those two descriptions that you've made, Hayden. As well as that, in terms of the overview point, not just from the scrutiny role that we have dealing with issues like this, I'd like to know, and forgive me if I missed it because you did whirl through it, love. I'd like to know what your plan and timetable is in terms of these visions and strategies that you've put out there. Because if you don't have a time and a plan, then I think our patchy and bleak position, as well as our hotspots, we're never going to see or may not see any influence of your vision within the strategy. So I think it's important that we all get to know what those are, either through our local place and how they're actually dealing with it at local, as well as yourselves. The urgent care access, brilliant idea. But as you've said, Hayden, across all our authorities, urgent care access obviously is an improvement in principle. But in trying to get a dental appointment, from what we're told in our local place and our local authority, as the chair has said, in terms of prevention, it's to get that appointment in the first place. And lastly, in terms of the young dentists and recruitment as well, and when they've gone through their training period, we did have a question at a previous committee about extractions and infections and referrals to the hospitals. There was a statement that was made that virtually described the situation of why antibiotics are referred to in terms of a patient going to a dentist, and the ongoing situation that there seemed to be concerns or a thought, or certainly the impression that the younger dentists who may not have or feel they have the quality of skills to do extractions are actually prescribing antibiotics. But then when it gets too far, the extraction is taking place within the local hospital situation. I can understand there's probably a reasonable time in which experience of extractions has to be taken into account. But if that's an ongoing problem, we're just referring the issue from the dentists across the patch or across the district onto the health service. And my question on that is both to the Dental Commission and to the Public Health. Is there any records or data kept of how many people are actually referred from our dentists across the ICB and at local place that would actually enhance that view that was given? Maybe it was a place and time, but is that still the situation? So thank you for that, Chair.
Okay, thank you. Yes, and I would like some information as well on the appointment situation. I do know one Sunday in October, there was no emergency NHS dental appointments available across the whole of Yorkshire and Humber for a child that was in need of a dental appointment quickly. And to get one privately, it was over £100. And therefore, you're saying you're having more access, but in practice at this moment in time, it's very difficult. However, I'll bring Rachel in first on the fluoridisation questions. You represent Directors of Public Health, Rachel, don't you? Yes.
Yes, I do. Thank you. And hi, everyone. Just very briefly, I think one of the challenges with this agenda is that from a purely public health perspective and evidence, the evidence is overwhelmingly supportive around fluoridation at a population level. I think the challenge will always arise in terms of personal choice and the perception of what people would describe as mass medication of the population. So I think that what we found in historic scrutiny type discussions at local place level is that there are a huge cohort, well, not a huge cohort, but a strong cohort of the population who fundamentally disagree with the concept of being provided medicine or the equivalent of medicine without their permission or their control. And I think, unfortunately, as a result of COVID and the kind of polarization of views around vaccination, what you find is there are people even strongly holding those sorts of views as distinct from others. And I think for those members and the councillor who obviously is from an area where this was in place from many years ago, in a way that's a lot easier to manage because it's not something that we're trying to add in, it's something that's already been there. And that's why I think the central decision making moving to obviously ICB recommendation is positive. But the challenge will be, I guess, as a scrutiny function on the West Yorkshire level, is how we manage that public opinion versus what is a really strong evidence base. And I think that you can see quite obviously in people that are growing up in areas where fluoridation is present, that the levels of decayed, missing and filled teeth is just nothing like what we see in West Yorkshire. So it is a really challenging one because there is an element here of public viewpoint and certainly that element of, do we mass medicate the population, or is that something that actually enough of the population disagree with? So I think that was just the context of that, and I think that's why as an ICB it's a real challenge in terms of working out how to position that to best reflect it. But public health population level, we know it's definitely the best thing. I hope that helps, Chair.
Yeah, thank you. Hayden, are you coming in on the Councillor Rhodes' other questions and fluoridisation?
Yeah, absolutely. Thank you, Chair, and thanks, Councillor Rhodes, for the questions. I'll take the flexible commissioning one and the 6-weekly update one first, and then I'll get into the data question. So firstly, apologies if I rattled through. I did want to leave most time to discussion, and hopefully it's been a good discussion so far for colleagues. And these 2 points linked together, really. We did produce some time ago a pretty short briefing on flexible commissioning as a sort of example piece of work. And if councillors would find it helpful to be in the space of receiving periodic updates on the progress we're making, perhaps in the next and first update we send out, we could attach a bit of a briefing on flexible commissioning, for example, if that would be helpful. That briefing will need a little bit of updating from the last time we wrote it. So yeah, absolutely committed to doing that, and happy to have that bi-directional dialogue. And just for noting, I suppose, and it was a short while ago now, we did share a written letter that was sent out through our comms director and comms network to all council execs that we hoped was cascaded to. There was an update at a point in time, but yeah, I'm happy to make those more periodic to make sure that members here and others feel more connected to the work that we're doing. On the data question, I suppose, and I suppose to unpack my patchy and bleak strapline, if you will, and they are two distinct things. I think the patchy point, the fundamental point here is the data that we use is disparate. So we have different sets of data that we try to bring together for best effect. So if I take a couple of examples, Councillor Rhodes, you touched on the hotspots. So that is a set of data that we get currently on urgent dental care that tells us the number of appointments being delivered where those appointments are being offered and delivered, and also where they're not being offered and delivered. So we can overlay that data onto a map of each area in West Yorkshire that will, if you look at that map, you may see a particular dark spot, i.e. no or few appointments in a certain area. So we can use that to best effect to say there's a gap in provision here, there's a gap in access. And noting, Chair, your point around some of the examples as well around that child on a Sunday that couldn't get an appointment. I'm not aware of that case specifically, so I'd have to take that away, but more broadly, we can see where access is and isn't, and we know that overall, even though we're investing a lot in that, there is still a shortfall and high demand. And so what we do because of that patchy or disparate position on data is we try to use different ones. One of the challenges we've got with the contracts in the dental system is it fundamentally only counts the UDAs delivered, not much more, not much less. And if we're saying that system is a problem, what that data will tell us is also a problem. So it doesn't tell us anything of tons of value all of the time. And that becomes really challenging. What we've also done through our additional investments is through that we attach our own sort of measurement framework to things through something that we call a snap tool that gives us better insight into what's been delivered and what people are seeing when they look in patients' mouths. So we're trying to sort of coalesce that along with the data that sits perhaps more in the public health space. So the epidemiology survey, as an example, one of the key questions they will ask this time around is about the presence of caries in children's mouth. And we could get that data and use that. Clearly, problems alluded to is lack of provision of that survey, and so lack of knowing effectively. So we try to bring those things together. When I say bleak, I probably mean two things. One is the data that we do have, and when I say data, I mean the numbers we get on a spreadsheet, but also the feedback we get from patients will tell us probably two key things. One is that the state of oral health is not great as a result of inability to access services and a protracted time period that's gone on for. The second is inability to access services themselves. That's the bleakness. Not enough provision, deteriorating oral health, and so we take the best understanding we can, and we're trying to improve that. And finally, Councillor Rhodes, you asked the question of can the data be broken down locally, and because of the patchiness of said data, some of those data sets will lend themselves well to being able to do that, some less well. And so there's a point within the paper, I forget which number it is, where we note our commitment to developing a better measurement framework through the West Yorkshire Joint Forward Plan refresh this coming year. It's within that scope that we can start to address how we better align data sets, improve what we measure, and show what's going on at the hyper local level, so we can really target additional access and make a difference. And you asked one more question that I just remembered about a plan and a timetable, and we've been asked this question too. So I think understandably priority has been to developing the plan to spend that £6.5 million and spending it. And if we didn't do that at pace, we had to spend that money in year. So that was absolute top priority. And so other things have sort of been immediate, mid and long term. And we have been challenged before and here now, and it's a healthy challenge to develop a more distinct plan that has timeframes attached to it. And that's the space we're now in. Now that plan is sort of delivering itself because we've put the mechanisms in place, we're in the space of doing that. So again, perhaps through updates or perhaps through future discussion, we can offer greater clarity and assurance on that. Hand back to you, Chair. Thank you.
Thank you very much. Thank you. I think we would welcome greater clarity around your plan with timeframes. I think we would welcome that. Councillor Blackburn, you've been very patient. Thank you.
That's okay. Well, I welcome Councillor Rhodes' input. It's extremely helpful and raises a number of extremely valid points. Equally, Hayden, thank you very much for the report. I noticed in the report it did amuse me because it said the challenges are deep rooted. So it did amuse me to an extent. So, but actually, I'm really keen that this is kept on the top of the agenda. It's been on the bottom of the agenda for far too long. I remember former Councillor Marilyn Greenwood first raising this at our Scrutiny quite a number of years ago. And I think, whilst we're making progress, it's just not fast enough. And actually, the element from my perspective is the communication. I think it's at the moment, I would say, it's ineffective communication what you're doing, because what you're telling me, Hayden, is absolutely, you're making great steps, but actually this isn't communicated effectively to members of the public, and what you are doing is great in some ways. And I suppose the other element from my perspective, given the cost of living crisis and given the number of people that are having to use food banks. Are we communicating equally with the food banks and actually providing them with, you know, toothpaste, toothbrushes? Because actually, it's one of the things that people think, actually we won't bother with toothpaste. We have to eat, or we have to heat the homes instead. So it is one of those issues in some ways. And I suppose thirdly, is there anything we should be doing council wise that would promote and help in terms of our public health? So is there something that we should be doing to actually support more what you're doing? So I think those are my key questions. So you know, appreciate the report, but say it just needs to be at the top of the agenda. It needs to stay at the top of the agenda, because actually it is causing us greater problems, health inequalities and health wise.
Yeah, thank you. Jane, did you want to come in on any of those points?
Just a point that Councillor Rhodes made about antibiotic prescribing. I'm the urgent care clinical lead for the ICB and chair the urgent care managed clinical network. We audit antibiotic prescribing to make sure that it's within the correct limits. Any outliers are identified for training. If if clinicians are prescribing antibiotics when they shouldn't be, we do something about it. And the patients would not be referred to hospital for the extractions because the hospital would reject them. So just to reassure everyone that that's not happening.
Thank you. Hayden, did you want to come in on the...
Yeah, just to reflect. Yeah, just reflect briefly on Councillor Blackburn, your points, and thank you for them. And I welcome the healthy challenge and the request that this remains an urgent priority, one that's delivered at pace and top of the pile. And that's absolutely the commitment that we've got from an ICB perspective. It's absolutely one of the top priorities. We tried really hard, and what you're telling me again, healthy challenges, that perhaps the communication can be improved. So I take that on board and absolutely commit to do that. Hopefully the things that Councillor Rose has raised in terms of my communication with you on a more periodic basis will help that, but also things like our dental patient reference group and working with our comms experts in the system to deliver better messaging and working with practices to deliver said messaging where people interact with people on a daily basis. I think that's important. And to your question of anything that we should be doing, I think if you guys are going away back into your respective council systems and you're saying here, this is the top priority, if that message is just continue to be pushed, I think that's the best thing we can do, and that we're all singing from the same hymn sheet on, we know there are significant challenges, we're doing a lot to try and improve it. We know we need things like national contract reform, water fluoridation, long-term dental workforce planning, and we're all banging that same drum. And I think Councillor Scope suggested earlier that we support a letter written nationally. Those sorts of things are, I think, the most powerful thing we can do together to support that messaging, both upward nationally and into local communities too.
Okay, thank you. Councillor Addy, do you have any points you wish to raise? Yeah.
Yes, still. I was looking at the 25% flexible commissioning, and it's great to be targeting people who haven't had access to dentistry, of course, but this is 25% of existing capacity, isn't it? And I don't really see how spreading the butter thinner on a different part of the toast is engaging more people. These people who are getting this extra urgent care that haven't seen dentists for a long time, do they then get to see an NHS dentist on a regular basis? And there's a whole cohort of people who don't qualify for free NHS care, free dentistry, who really struggle to pay even the NHS level, never mind go private. So even for them, how do we get them to engage with the cost of regular checkups, which prevent the more severe need? But the primary thing in all that is, if you're taking 25% out of this and putting it into specific areas, I don't know dentists in my area that have any extra capacity, and you know, the waiting list for NHS dentists are massive. Are we going to engage with more people or just different people?
Okay, thank you. Councillor Swift, can we take your points at the same time, because we're running out of time? So are your points on the same?
Yeah, it was just really to, I'll cut out a couple of my points, and I'll just stick to a very strong reinforcement of the the notion that we do actually write nationally. I was particularly disturbed by Joe Hendren's comments, not by his comments, but by the content, where I think his understanding was that the Department of Health were actually positively not currently addressing the dental contract, rather than simply not making very much progress. So I certainly would speak very strongly on that point. Thank you, Chair.
Okay, thank you. Peter, did you want to come in on Councillor Addy's comments?
It was more Councillor Blayberg's comments
Right.
around the integration piece, and certainly in the paediatric space, which is where my specialist practice is. So I'm one of those paediatric dentists who takes teeth out and does looks after the children under general anaesthetic. It's very much around that integration, certainly the preventive piece of turning the taps off. It's around working with nurseries and education settings to support some of those public health activities, which again, if we can reduce the levels of dental decay, there are less needs on the health service for the provision of dental treatment, whether that's in hospitals or in dental practices.
Okay, thank you. Hayden, did you want to come back on the 25% question?
Yeah, absolutely. And so yeah, you raise a good point, Councillor Addy, in terms of spreading thin, because we are making more of what we've got effectively, and so we want to engage more practices, so we fundamentally increase the number that we can substitute 25% in. So that would be more additional, if you will. One of the other things, without getting awfully technical, is at the moment to qualify for the programme, you have to be at a certain level of performance. And if we are substituting 10% as we are at the moment to only those that deliver above 90%, we're creating nothing new. But actually, if we lower that threshold, we can start to create pockets of additional activity. One of the other things about that as well is, because of the problems with the contract, the current system doesn't necessarily incentivize the right access, if you will. So you will perhaps see people coming back on, say, a 6-month recall to have their teeth checked, which may be important for some, but may not be important for others. And we're able to better direct access to those that most need it to prevent further deterioration. But I absolutely take your healthy challenge that we have to be making the best of it.
Thanks, thank you. John Beale,
Yeah, thank you very much, Chair.
So,
apologies first that my camera doesn't seem to be working today, so I'm...
All right, and if you could say where you're from as well, please.
I will indeed. I'm representing Healthwatch. I chair Healthwatch Leeds. My background is that I'm a retired regional consultant in dental public health, so I've been involved in the dental scene for many years. Really just wanted to say, first of all, there are things that can be done at each level, things at place level, at regional ICB level, and national. And I think in answer to Councillor Blagborough's question, I think that each of the 5 place areas in West Yorkshire have oral health groups working within or alongside the public health departments of the local authorities, and I'm sure that they could give you information about what they're doing, carrying out such things as supervised toothbrushing in schools in the most deprived areas, and that's going on in all 5 place areas. Secondly, at ICB level, Healthwatch has been very much involved with Hayden and his colleagues since they took over responsibility for commissioning dental services. I have to say that certainly in Leeds, the number of phone calls that we're getting, while still one of the main reasons for people phoning Healthwatch, has reduced, but that's partly, I think, because we've now got a section of our website which gives information which hopefully means that people don't necessarily have to phone Healthwatch. But what I wanted to say with regard to the ICB, and we've worked, as I say, with Hayden, is that since they took responsibility, and it was only in April, so we're only sort of 6 months, a bit more than that, in the time that they've been responsible, there's been very much a can-do attitude, a positive attitude. What can we do at ICB level? Now, proof of the pudding will be in the eating, but certainly the sorts of things that Hayden's been talking to us today about, I think will, over the next months and a couple of years, if they come to fruition, will make a dramatic increase in the availability of NHS dental care. That's not to say it'll be perfect, because coming onto the third level, there are some things which can only be done at a national level, and the contract has been mentioned. It was introduced in 2006. There was a major review of how it was going in 2008. There was all party support for making changes, and apart from a few minor tweaks, nothing has been done since 2008. And it really is time that centrally the government, whichever party is in power, actually does something about the contract, which we've already heard is a major blockage to improving the situation, and is leading more and more dentists to reduce their commitment to the NHS, and a number of dentists leaving the NHS altogether. So there's the contract. There is secondly workforce. We don't have enough dental workforce. It's not the only part of the NHS which is short. We're short of doctors, we're short of nurses, we're short of many other parts of the NHS, but we're certainly short of dentists and indeed dental care professionals, that is dental therapists, dental hygienists and dental nurses. And thirdly, there funding. Joe has already said it's only funded to the extent of we could only afford for the NHS money to pay for half the population to get dental treatment. The workforce means that we've only got enough workforce to attend to half the population. So workforce and funding go hand in hand. And justly, very quickly on fluoridation, I do have to declare an interest. My PhD was concerned with monitoring the effectiveness of water fluoridation in Birmingham, and I am currently vice chair of the British Fluoridation Society, which campaigns for extending water fluoridation in England. But the only one thing I just want to draw your attention to is that not long ago, all four of the national medical officers of England, Wales, Scotland and Northern Ireland all strongly recommended fluoridation. So it has very wide and top level support within the Department of Health. Thank you very much, Chair.
Thank you. I'm going to bring this item to a close. So Joe, is it really quick comments, please?
It is, yeah. It's in response to Councillor Addy. The workforce is as it is, the 25% flexible commissioning is to try and overcome the idiosyncrasies of the current dental contract in order to provide time for those practices that can't provide the care under the UDA contract, under the current contract, but to work things differently and to work hand in hand with the toothbrushing schemes that we have in Wakefield. And I know Peter Day's been working in Bradford for those. So it is going to enhance access to more prevention, which the dental contract doesn't address at all. It also will address access for those people with urgent care needs and those asylum seekers and people less able to access dental treatment. Just one final point. I'm a national representative and within the BDA, the British Dental Association, and we had a presentation from all the different ICB areas last week, and it looks as though West Yorkshire and Humber and North Yorkshire are the two ICBs that have really put dental access and the dental concerns right at the forefront of their policy, and these guys are really should really be commended and supported in the work that they do.
Okay, thank you. Right, so from our discussions then, can we first of all thank Healthwatch for coming and giving their thoughts, and can we thank all the officers and practitioners that have come today as well to answer our questions. I know that in a number of authorities in West Yorkshire, there's been a lot of concern, scrutiny concern on access to dentistry for a long period of time. So I think we would say that we welcome progress because we have been keen for a long time to get some progress in this area. You say that the plan that you've drawn up, you're going to have timeframes for. So we would like to see those timeframes. Yes, please. We would. I think everybody would like the information, the data information on the dark spots that you said that you could provide. I think we'd also recognise there needs to be a greater communication of progress. And I think also we'd like to know about those workforce plans when they are more developed. I think we'd like to know about those. As far as the recommendations are concerned, we would like a 6 weekly update on progress as per Councillor Rhodes's request on the vision and your plans for the future. On the fluoridisation, I think what we're saying is that we would like some more information, detailed information on this area for further discussion in this area. I think that's what we would like to have, and we would like to know your update on your progress in your discussions. And we would also have a recommendation for this committee to write to the government about the national contract and ask for them to bring forward reform as per Councillor Scopes's point. I hope I've covered everybody's. Councillor Rhodes. You're on mute, Councillor Rhodes.
Here. Thank you very much, Chair. I apologise. Can we just have the issue that you referred to under the bullet point on fluoridation? Can we have that amended to incorporate the words that you've said about the fluoride and more information, rather than it just be left with support?
Yes. We will alter those words so it says provide more information to the members of this committee on fluoridisation, so we can have further discussions on that. Yes,
thank you,
that
Chair.
would be the recommendation rather than the one that's in the papers.
Thank you,
okay.
Chair.
Thank you. Right, thank you for that. So can we move back now to the urgent care service review, please? John, I believe this is your area.
It is, yes. And can I just start off by apologising for missing you out at the beginning of the meeting because I wasn't able to join at the beginning, and thanks for colleagues from dental and oral to be able to fill in for me.
Okay, and if those colleagues need to leave, please feel free to do so. Yeah, okay. John, over to you.
Okay, so for those of you that don't know me, my name's John Parnaby. I'm the Urgent Emergency Care and Unplanned Programme Lead across the Mid-York system. But for this piece of work that I'm discussing today, I've been asked to do a piece of work on behalf of the whole of the West Yorkshire ICB, and that is the review of a West Yorkshire contract. So this is the West Yorkshire Urgent Care Service Review. The West Yorkshire Urgent Care, in effect, is many of the services that are provided by LCD, Local Care Direct, which is the provider that provides a lot of services across both Yorkshire and Humber. What I want to emphasise is that with this service review, it is indeed that. It's a review of services. It's not a contract review, and it's not a provider review. I'm not reviewing all of the services offered by LCD, and although there is a contract review underway, that is not incorporated into this piece of work. I'm working with those colleagues, but it's not incorporated into this piece of work. So a very brief bit of history about this. With the Wyatt contract, originally started about 10 years ago, and it was primarily for the GP out-of-hours services. It has grown organically over the past 10 years. So it's had additional aspects for West Yorkshire added into it, such as practice learning time for GP practices, things like the West Yorkshire Clinical Advice Service has been added into it, but there's also been more local services that have been added into the contract. So things like the staffing and working of the urgent treatment centres, the 2 urgent treatment centres in Leeds, the provision of a safe haven service in Calderdale and Kirklees, and so on and so forth. So it has grown organically over the course of the past 10 years. The contract value is over £20 million, nearer £28 million. And this is the first time that this kind of service review has been done on the contract or done on these services once at West Yorkshire level. It's the first time a contract like this or service like this has been reviewed since we've become an ICB. Previously, in CCG times, it used to be a case of CCGs used to tweak and amend their little bits of the contract on their own. There was nothing done across a West Yorkshire basis on it, and the contract then rolled on and rolled on and rolled on. So, like I say, I'm doing this on behalf of the ICB. So this is why we're here at the Joint Health Overview and Scrutiny Committee, but it does mean that we are also working with our place urgent emergency care leads to make sure that all places are being brought along with us. The way that we've actually broken down the services is into 3 different work streams. So you've got the primary work stream 1, which is in effect the GP out-of-hours service. So this is the service that kicks in Monday to Friday, 6:30 till 8 in the morning, weekends and bank holidays. And this is the service whereby if anyone needs to see a GP within those hours, the agreement with all GP practices across West Yorkshire is that it trips into this GP out-of-hours service, and it is then serviced by LCD as far as any GP out-of-hours provision. So that is work stream 1. Work stream 2 is a relatively new service in that it's only a couple of years old, and this is the West Yorkshire Clinical Advice Service, and this is whereby when people go online and do an online assessment on 111, and they can do that online, if the final disposition or result of that is you need to go to ED, there is an option, instead of immediately going to ED, there is an option for that patient or resident to actually click through and have a call from a clinician from LCD. So it may well be that the may not need to go through directly through to ED, because unfortunately ED sometimes is a default. People are turning up at ED because it's been a default position on 111 online, and so therefore it is much better as far as the patient experience if they have an opportunity to speak to a clinician and they may not need to go to ED. There's many calls that are closed in that way with having this option, but it is an option for the patient or resident to do. That they don't have to do it, it's just an option that they are able to do. The other disposition that LCD would satisfy under that West Yorkshire CAS clinical advice service is if 111 came up with an outcome that you need to see a GP within 1 or 2 hours. It's a case of like, well, that would go through to LCD for them to either arrange a face-to-face consultation or a telephone consultation, or be able to sort of like support that person in there. So that's all included in workstream 2. Workstream 3 is everything else that's fallen into this contract organically. So as I've mentioned, you've got the urgent treatment centres in Leeds, you've got the 2 urgent treatment centres there which are run by LCD. You've got things like the practice learning time. So this is where practices close for staff training, usually on a monthly basis for an afternoon or whatever. And the phones are tripped through to LCD. LCD cover that within this contract. It's for things like the Safe Haven project. So Safe Haven is what is known as the GP of last resort, if you like, and this is where patients may have been excluded from a number of GP practices because of behaviour, etc., but we still have an obligation to support them. So we do that through a safe haven service, and that is only in this contract for Calderdale and Kirklees. So that is all within workstream 3, so like all of those additional anomalies. So when we started this piece of work, we were aiming to have it all finished by March, and we are still going to have it all finished by March. But the options that we were going for was, well, do we have this big service review and have a brand new specification available to LCD to implement over the following years, to say, right, okay, well, this is the new specification that you've got to implement. That's quite an old-fashioned and hard way of doing things. So what we've actually gone through, and this has been approved by our various SLTs and programme boards, etc., is we are developing what is known as an SDIP. So this is a Service Development Improvement Plan. So it allows for further discussion on all of these different areas to continue within the new contract period. So it allows for those discussions to continue with partners. And when I say partners, it's continuing with a health watch, with patients, with GP practices, with all partners involved in the services, to then refine the actual services that are going to be included within the Wire contract. It's all done on an SDIP as far as it's got very tight timelines. It's not just a case of like, well, here's the number of improvements we want to see, and we want to see them by the end of a 2-year contract. It's a case of all of those SDIPs, all of those service lines will have specific outcomes agreed with the provider and timelines agreed. So it may well be the improvements to the GP out of hours service or the primary care centres that are offered. They may need to be done in the first year. The Safe Haven project, which is in Calderdale and Kirklees, it looks as though that may be coming out of the contract, so we may need to see that in the first quarter of the new contract, and so on and so forth. So it's all very strictly monitored with our contracting colleagues, with the support of the Urgent Emergency Care Commissioners. So really, it's just a case of why I'm here is just highlighting to everybody this is happening. What we are going to be doing, there's some big engagement pieces that will happen once we know what's going to be included in the SDIP. Those engagement pieces, depending as to what they are going to be, may be across the whole of West Yorkshire, if it's a service that's affecting the whole of West Yorkshire, or it may be individual engagement pieces if it's a service that's within the contract but only affecting specific places. So, for instance, if there was a proposal for the urgent treatment centres in Leeds to have different opening hours, for instance, because we've looked at the data and it's better for them to open between X and Y times as opposed to A and B times, there'll be further involvement and engagement pieces across that Leeds footprint and with our OS colleagues across Leeds to take that through various governance. Similarly, with the Safe Haven project, it will be Calderdale and Kirklees that were taken forward. If there were going to be some huge changes proposed, and I don't know if these are going to be proposed, as far as the GP out of hours service, for instance, it's been around for 10 years. It starts at 6:30, ends at 8 the following morning. Is that the right time for it to be doing? It was 10 years ago, but now we also have enhanced access services in primary care, and they're open till 8 o'clock. So there's an overlap between 6:30 and 8 regarding services in primary care for same-day appointments. So if there was going to be changes on something like that, that would be a much wider engagement piece across the whole of West Yorkshire, and that will be incorporated into the SDIP. So that's where we stand at the moment. We like I say, we hope to be on track, be able to take the SDIP through formal governance in the first quarter of next year, January through to March. As far as contracting, the contract itself expires at the end of March, and there is a direct award to the current provider being agreed with contracting colleagues and the provider for 2 years, starting the 1st of April of next year, to allow us to incorporate all of this SDIP improvement aspects within the contract itself.
Okay, thank you. Can I just, it might be me that's misunderstanding. Okay, so can I just have clarity around this? Because this, I'm not quite sure that I've altogether followed. So you're going to have a service development and improvement plan.
Mhm.
What are your timelines for that? Because you're saying in the next paragraph that you will be incorporating that into the new contract from 1st of April 24.
Yeah.
But then that will give more time for review. So what is it that you're putting into the new contract, and when do your reviews happen, on what services, etc.? How is this working? Because I am really not following. If you're putting it into a contract on the 1st of April, the services that you are requiring for a 2-year period, how you're then going to be changing services over time. That bit, I'm really not with you on it.
So with many service development improvement plans, they're actually issued within a contract, and it says, we expect you to see X number of patients more than what you are seeing now. And then that's monitored over the contract period. We're not doing a service improvement plan in that way. What we are saying is that within the service development improvement plan, with each service line, so again, if I just take Safe Haven as an example, that Safe Haven service may be coming out of the contract. So the service development improvement of that aspect is a case of that needs specifically reviewing. Does it meet the standards of the national specification that was issued last year? If not, what needs to be improved, and our LCD in a position to do it? And if they're not in a position to do it, how do they go about commissioning a service with a different provider and taking monies out of that contract in order to service it with a different provider? And that could be done within Q1 of the new contract or Q2 of the new contract. It will have a specific timeline on that.
Right, so you're contracting LCD to carry out the reviews on the services that you wish to have reviews on, or they can contract out again to do those reviews. The ICB itself is not doing the reviews.
The RCBs are involved in the reviews because we don't want, as commissioners, we want to have an input into those reviews. So we will be taking forward those reviews with LCD. It's in the contract, so we expect an outcome within the contract of those improvements to happen. And they're the ones that are agreed with the commissioners and our local populations.
Okay, I think everybody's looking just as confused as I am. Councillor Swift.
Yeah. Yeah, and the more the explanation goes on, the more baffled I get. I mean, first of all, the commissioners, is that the ICB, or is that, or if not the ICB, who else? Because I mean, John referred to we and referred to the commissioners as being separate people. So can we have clarity, first of all, as to exactly who's doing the review? Because at one stage, it almost seemed as though LCD themselves were kind of doing the review or party to the review. And also the nature of this contract that extends from the 1st of April. Generally, if you've got an incomplete review of what you want out of a contract, it's not uncommon to extend the current contract for a shortish period while you're sorting out what you want in the longer term one. This one sounded a bit like the contract gets extended, but then in some way the service provided under the contract gets changed after the contract has been entered into. So yeah, so clarification on those kind of points. I'm sure I'm not alone.
Okay, so when I'm talking about the commissioner, there is no one commissioner that commissions services for urgent emergency care in the ICB. There are 5 place-based urgent emergency care commissioners who meet regularly and have direction within this contract. So like I said, so it's the 5 urgent emergency care commissioners at place that would be directing exactly what is going to be happening at place. So is that okay?
So I think what you're saying is then that it's the 5 place commissioners that are commissioning LCD and telling them what's in this 2-year contract.
Yeah.
And in that 2-year contract, there is, you will need to review X service.
Mm-hmm. Yeah.
And that review then involves those place commissioners, but it's LCD that are running the service that's carrying out the main part of the review. Have we got that right?
They are doing the main part of the review as the service provider, but it's in association with the actual commissioners, because we're the ones that have got all of the data and detailing how the contract is being run, are they meeting their obligations under the contract, are they delivering the specification.
Right, okay, so is it a partnership approach then as far as the reviews are concerned?
Yeah,
but how then do the commissioners hold LCD to account to on the information that they provide to say whether that service review is has been carried out in the way that the commissioners wish it to be?
What will happen is at the monthly contract meetings run by contracting colleagues, with an STIP now being incorporated into the contract, there is a specific section on the STIP, and they need to feed back on each service line within that STIP as to how they've progressed. Commissioners then have an input into that discussion as to that you haven't progressed enough, or it's not developing as we wanted to, or the direction isn't going in the direction that we and our residents actually want it to go. So then that discussion would happen at the contract meetings, which happen monthly.
Okay, Councillor Swift, did you want to come back at all before I bring Councillor Hutchinson in?
No, I'm just happy to let the discussion roll. I think other colleagues will kind of pursue their degree of uncertainty as well.
Yeah, Councillor Hutchinson.
Yeah, I mean, I must admit, I'm having great difficulty seeing what we are able to actually scrutinise as a board. It seems so fluffy. You know, looking at Appendix 3, there's a very clear timescale that's been charted in Appendix 3 of the paper that's been brought forward to it, but it doesn't sound as if that actually means anything. So I'm really not certain at what point we can assure ourselves of the quality of the service that is being provided, and whether we feel that the contract that's being provided is the best one for the people that we represent. There doesn't seem to be any clear point at which we can do this. But again, that might just reflect my poor understanding of what's been told to us this morning.
Yeah, John.
So within the paper, it does talk about a lot of engagement that's already been done, and the fact that in doing that engagement, our residents and patients are happy with the services. So that's what it's saying in the paper, and that's what's happened with a lot of the engagement and reviews that have been done with our engagement and consultation colleagues. So their recommendation was it's not a case of letting a brand new specification, but actually improving the services that we've already got in the contract.
I mean, for example, you've said that the safe haven that's provided for Calderdale and Kirklees may be taken out of the contract, but you've not said why, or whether that means it's not going to continue, or what. And you know, I would be the local clinical advice services. We've got so many. There was a big drive towards diverting people away from emergency departments for a number of years, and now it's been generally accepted that that's a failed strategy, and yet it seems to be something that is being pursued here. Where can we find the evidence to say how effective the local clinical advice services are actually proving to be?
So we do have all of that data to hand. That service has been running for just over a year. They do divert, I think it's about 800 attendances at local EDs that stop those attending, because these are people that are then choosing, instead of to attend ED, because that's the disposition that they've had on 111 online, they are opting to click through and speak to a clinician, and then they're able to give them further advice, which may not be, like I said, the default position of attending ED.
Okay, so where is this information published? You say you have this evidence, but where is it actually published?
It's within the contracting meetings that we have with LCD, when we're going through all of the different service lines with LCD about activities that they are incorporated into their contract.
I don't know about fellow board members, but from my point of view, I don't feel we have the information to hand to be able to make any kind of recommendation at all today. But I might be
I agree. Yeah,
alone.
I agree. I think this is different, isn't it, from what earlier conversations that we've had. Councillor Rhodes.
Thank you, Chair. I've been around a long time, myself and Councillor Smaid as the Chair. And I have to say, as this report is presented, I think everybody's probably shaking their heads at what it is intended to do, to be, and to inform. First of all, I think the information at this stage, where John has said that in the new year things move that fast, it's impossible to understand why it's taking so long for this to come, and the time pressure that's on it. First of all, John, you're speaking about contracts, and contracts are procured through commissioners in the various places. Yes or no?
Yeah.
Okay. Now, in terms of the procurement of the contracts, and you've had this review, you've mentioned one area that's going to be pulled out already.
It may be pulled out, sorry, it's not a final.
I beg your pardon, John, may be pulled out already. And the information that's been given to you as an overview from the 5 authorities then is their opinion of the local outcomes of procurement locally. Is that right?
Yeah.
Okay. So in terms of those procurement contracts, when you've looked at them through, I'm saying the procurement group, how have you assessed the value, the outcomes, and the quality of those outcomes at each place? Has that happened?
Yes, it happens during the contract meeting, although it's not procured at place level. It's one contract run by Kirklees on behalf of the ICB. So that's why we're calling it the West Yorkshire Urgent Care Service Review, because it is a West Yorkshire contract. As I've said, it has grown organically because some of the services, as I've mentioned, are in this contract, but they are not West Yorkshire contracts. It's not like the GP out of hours, which is the original intention. That's across the whole of West Yorkshire. There are other elements and services that have been dropped into the contract over the years, which are not West Yorkshire elements. They are more local place elements.
Okay. Question in terms of each authority then. The contractual obligations then procured, which is a contract, through each organisation, do they start and finish at the same time, or are they just a moving picture?
They all start at the same time. When they've been incorporated into the one contract, they've been incorporated into the single contract term. So anything fits and goes along up until the end of March currently of next year.
Okay, so during this period, now that you're going through this review, I'm assuming again, as contractual obligations, you will have, and there's that many fingers in it at the moment, I'm trying to dissect it and see who does what in terms of quality of the contract. You will have then on your contract, the monitoring of that contract in the 5 authorities over the contract period, which you're saying is 2 years, yeah?
Mm-hmm.
And obviously as things change and move on, then I'm assured that that's reflected in why you're doing the review. So I'm going to go back into the contract now because there's only one area mentioned that may change. Has the outcome of that procurement of those contracts across each place shown that the commissioned services have actually delivered what was expected in the contract?
Yes, and that's why we're looking at service improvement as opposed to dismissing them or whatever. It's a case of it's a service improvements that we're able to make. You know, is it an improvement to a service to have it starting at different times? So the core GP out of hours service, is it better if that service starts earlier or later? Similarly with the urgent treatment centres, is that in Leeds, is that reflective as to what the demand is in Leeds? That has been reviewed and that is correct at the moment as far as their opening hours.
Okay, so you are satisfied. I'll ask the question again. You're satisfied in the last 2-year period that those services commissioned through local place have actually delivered what was mentioned in the contract to the quality of the contract? Or has it given an opportunity in this review of the contract obligations to actually look to see if more could have been done within that contract, which you could implement in a future contract?
There's elements that can be implemented differently in the new contract. If I take the example of primary care centres, there's 12 primary care centres which accept referrals out of hours into primary care, and there's 12 of them across West Yorkshire. And there's always been 12 of them that since, actually there was 11 and then it expanded to 12 across West Yorkshire since the start of this contract. So since 10 years ago, they had these primary care centres. The way that those primary care centres work now is very different since COVID, because there is a lot more telephone and video contact as opposed to the need for a physical primary care centre estate manned by receptionists and clinical staff overnight or on weekends. So it's an opportunity to say, well, how do we need with those primary care centres? Is there an opportunity to do something differently with those primary care centres now?
Can I come in there, John, and on behalf of the public now that we're speaking about, because this is a patient-led provision of need. You mentioned things have been different since COVID. That's not to say that the public will agree that the difference is actually something that's satisfactory, because as the public are concerned, they can't get to see a GP. And I'll give you, for instance, in my own case, I couldn't get to see a GP, and I'm not one of these that knocks on anybody's door more than I need until 10 or 12 days hence. And at the same time, I then asked, when could I have a GP call? And I was actually given the same day for the same call or the same face-to-face. Now, this is what's happening in practice out in the community. And I'm sorry if I'm probing your contracts, and I'm sorry if I can't get to the reasons why we're looking at some issues in depth more than we are. There is a recognition in the community then, it's a contradiction to what you've just said, that people can't get to see a GP and they can't get an online conversation with a GP in less than 10 days. So how has this impression come through that there is this change because of COVID, which pushed people in that direction, but it's even got worse since we've come out of COVID, because the people using the services out there, and I quote, and I'm sure I'm not on my own, John, are actually saying, and I quote, doctors' practices are still using GP, they're still using the code position, and we're out of that now, so why aren't they seeing more people? But yet you're seeing today that because of that, we can make a change. It's totally contrary to out in the real world out there. And I think that's something we need to be looking at here.
Yeah. John, if you could answer that, and then if I'll bring Councillor Scopes in then. Yeah.
What we're looking at here is GP out of hours. So it's GP out of hours. So it's not your GP practice down the road and how they manage their appointments and scheduling. This is GP out of hours. I've mentioned the dispositions that they have on the West Yorkshire Clinical and Advice Service. So for anyone that goes through that clinical advice service, they get to speak to a GP within the 2 hours or 4 hours of the disposition that they've been given. If it's then deemed having spoken to them, they would be able to see a GP at a primary care centre face to face, 2 o'clock in the morning up until 6 o'clock in the morning, because that's the service that's commissioned. It's an urgent service that is commissioned out of hours.
So have you done any work on how many of those out of hours appointments actually have been generated by not being able to get appointments during the day? And who did your engagement to say that everybody's okay with the service? I think those two. But I'll bring Councillor Scopes in, because Councillor Scopes has been waiting for a while now.
Yeah, thank you. I think my take is a lot of these questions are because there's not enough data in the report. And I can't emphasise that strongly enough. And I don't want to criticise you at all, John, but my experience of the Health Scrutiny Board, I've only just started in May being on Health Scrutiny Board, is that there's a lack of data. And so all the questions Councillor Rhodes had asked, if the data had been in the report, she wouldn't need to ask it. She could see it for herself. And I guess on that, I guess my two concerns are, one, are the LCD marking their own homework in terms of they're providing the service and then they're saying whether they meet the targets that they want. And I imagine you'll say, well, that's why you're overlooking, but I guess digging into that data. And then the second point is around metrics for success. So when you say we're considering cutting this service, what metrics are you using? Or is it just qualitative type feelings? And if because you already said it's not about the number of patients seen, is it going to be satisfaction or time waiting? And I guess what I would want to see before the timetable goes on is something around what are we looking at to make these decisions. And again, you've talked about the contract conversations, but our job here is to scrutinise your decisions. So we can only scrutinise those decisions if we see the data you've got behind you. So you've said, we've talked about, and so Councillor Rhodes has very eloquently said, have you done this? And you said yes. And have you got this data? And you said yes. And my take is, what I want to do is see that data myself. And so I guess there's a real challenge to you, John, in terms of, my personal view, and it's obviously up to the chair, not me, is that we need this report to come back to us urgently with like an absolute ton of data, and probably more than we needed initially, because now, certainly me, I'm a little bit nervous. So I'm going to want more data than I would have wanted anyway, about really, really definitively what you're looking at, how you're going to measure it, what are the outcomes, how are we going to measure success, how are we holding the LCD to account on marking their own homework. That'd be my comments. And yeah, John, I understand that this comes across quite tough. It's not a criticism of you personally at all. It's just, I feel like we need more data. Thank you.
Thank you, John.
So as far as the data, I mean, there's something like, I think it's about a 20-page report that comes in from LCD, which is scrutinised at the contract report on a monthly basis by our contracting colleagues with the support of commissioners. I can certainly produce a summary of that, because that gives you a summary of how many people are attending Safe Haven, how many people are going through CAS, how many people are going into primary care centres face-to-face and telephone. I can certainly do a summary of, say, like the last quarter's reports on all of that, so you can actually see all of that activity that is incorporated within this contract.
Okay, I agree, Councillor Scopes. We need more information. I absolutely agree with that. Councillor Addy.
My question was very much along the same lines, really, just to add a little bit. I was asking, looking at the detail and thinking what we can do with it. You say the reports here is got to be all in for the 31st of March to be added to the contract on April the 1st, but we need to see some detail before then. And I was going to look at it. If that's the end date and the delivery date, it goes straight into the contract. What's going to be scrutinised in the interim? Because that's a very short period of time. And are we going to get to see those? You've said obviously that there's some details that we can have a look at, but I was looking at the timescale because it's very short, really. If this isn't in a position to show detail now, when will it be, and how far in advance of that March 31st deadline for an April 1st implementation?
Yeah,
So,
John.
So if you're wanting data brought to your January OSCE, then that's fine, and then you'll see all of the activity that is in the current contract. But I don't know what. So you'll see all of the activity, and I don't know what influence that's then going to have going forward. You'll see the activity in the out of hours. You'll see the activity in Safe Haven. You'll see the activity in CAS. You'll see how many people are attending the urgent treatment centres in Leeds. So I can pull all of that activity from the contracting reports.
Okay, so can you tell us who did the engagement?
It was Colin from the engagement team. It was a desktop engagement. So he went through all of the engagement activity that had been done over the past 2 years through Health Watch and getting reviews as to how the services had been run. And then he made the recommendation that's outlined in the report.
Okay, so there wasn't any particular current engagement. It was a summary of engagement over 2 years.
That's right, yeah, but it's not to say that that is the end of engagement. As far as the Service Development Improvement Plan, if the Service Development Improvement Plan dictates that there's further engagement that's required, then that would be incorporated into the ESTA.
Right. And where is the assessment as to the urgent GP centres as to how they're operating in conjunction with normal GP practices, and how many appointments are going to the urgent that could have been dealt with during the day? Is there any assessment of that?
There's no assessment that I know of.
Right, okay. So
that GP out of hours service isn't bookable by an in-hours service. It's not like you can call your GP at 4:30 in the afternoon and say you need to see someone, and they can book you into the out of hours service.
Yeah,
They could
suggest to you.
They could suggest to you, if you call back at 6:30, you should be able to get an appointment within 2 to 4 hours with our GP out of hours service, but they're not able to book you into that service.
Okay, all right. So I think we're all a lot concerned about this. I think myself and Colin, I think we need some offline discussions about this as to how we bring this forward in January. I think we need some more information about what exactly is in these proposals and this change of contract. And I think what we also need to understand is in our individual scrutiny committees, what is being discussed by those place commissioners as to what changes are that are within the contract but are within place. I think I would suggest that everybody, I'm getting some nods, so I think everybody's in agreement that those discussions need to happen, yeah. But from a West Yorkshire perspective, I think we need to understand what a little bit more information, and that we come back in January with that information. Okay. And if people, if scrutiny committees in place have had scrutiny on areas within that contract, if they wanted to feed in then to those discussions on any discussions they've had, that would also, I think, be very useful. Thank you. Okay. All right. Thank you, John. But I don't think we can look at any of those recommendations in this report at this moment in time. I think what we're saying is we've got a lot of concerns over what this is at this time. Okay. Thank you.
Thank you.
Thank you. Right, so we now move on to the winter preparedness item. And do I take it, Deborah and Lou, are you here for the winter preparedness item?
We are. We're here.
Right, okay.
Shall we introduce ourselves?
Yes, please.
Hello, everybody. I'm Lou Auger, and I'm the Deputy Locality Director in West Yorkshire. Deborah, would you like to introduce yourself? Oh, you're on mute.
And I failed at the first hurdle. I'm Deborah Taylor-Tate and I work in the locality team with Lou.
Okay, thank you. So if you can see, we've read the paper, but if you want to highlight anything in particular.
So what you need to know about this paper, it's a briefing paper of things, a lot of things that have already put in place, the work that's already been undertaken, and this is for information. So it's to give you sort of an update of how we've been planning for winter. But we don't just plan for winter, we look at resilience all year round. So this is a continuous process. And we've had quite a few pressures already. It's not yet December, so it's really important for us to keep testing and reviewing plans. And then some of the winter plans last year really got tested. It was quite a tough winter. So we actually did our first review of what happened last winter in March. So we've been doing some learning since then and working really closely with each of our places. And that's where the winter plans start. Each of the places, our 5 places across West Yorkshire, all develop with their partners the detail around how they're going to respond to winter. And then there's a coordination role, which this paper helps to describe across the ICB. And the paper also starts to articulate how we ensure that we've got effective system working to help managing the challenges that we will come across this winter, no doubt. And it also brings together some of the national requirements and how we're responding to them and the government's arrangements that we've got in place. So it helps to take you through some of these different things. So I don't know how much time we've got to have a discussion or whether you've got some questions. We'd be very happy to receive them now, or if you want to email us, depending upon how much time you've got to give to this item.
No, we've got some questions.
Okay.
We always have questions.
You always have questions.
We always have questions. Councillor Hutchinson.
Now, can I ask about the System Coordination Centre? I can't make head or tail of the paragraph in 6.3 of the report as to what it's actually supposed to achieve, and what it will do, and also why it's necessary to contract an external partner to provide the service for in and out of hours. So who is this partner that's been contracted? I mean, most of the week is actually out of hours. Mm-hmm. So what's the purpose of this?
Yes. So the contracting bit, the in hours is done by the ICB team. So it's actually not using an external provider. The external provider is helping to support weekend working. So that's we're using the Next as a provider for that service. So they will work between the Northeastern Cumbria, the commissioning support unit. So they've been helping support us for a while. They've been actually supporting the ICBs across Northeastern Yorkshire with out of hours to help to support some of the rotas that need to go in over the weekends, and they work from 8 in the morning until 6 at night. And then after that, the ICB on call picks up any of the requirements on Saturdays and Sundays and bank holidays. During the week, normal hours, then it's our team as part of the ICB doing the pick up on all of the calls between 8 and 6 o'clock, and then it goes into the on call if there's calls after that. So that's the working arrangement and what's been contracted for, hope that's clear. Do you want to know a bit more about what the SCC is for?
Yes.
That's fine.
Yes,
we'll move
please.
to that then. I took the second question first. So Debs, would you like to just outline the SCC arrangements? And it's actually a national policy, so I'm sure we'll cover that for you.
Yeah, okay. So it is a national policy that was launched in December 2022. At very, very short notice for last winter, so which we brought together and we ran last winter. This year they have brought out a policy. Obviously, policies by NHS England are mandated, and we've had most of this summer to prepare to get ourselves into a really good position to deliver the 19 core standards for the SCC. It's difficult to go into a lot of detail, so hopefully this will give you a broad overview. It is there to manage the flow through the system, through the health and care system. So it will have a really, really strong focus on managing ambulance delays. It will have a strong focus on managing variances in attendances across emergency departments. And it will also look at flow through the system out into community services and adult social care. It'll support where people get stuck in the system. It'll support having those conversations that are really ground level with A&E departments and ambulance handover delays and YAS, and sort of brings the whole system together to understand where we've got our pressures and what we can all do to work together to try and anticipate those pressures, but also manage them in a more effective way when they do happen. Because I think what's really, really important is no matter how well we plan, no matter how much capacity we've got in the system, we pretty recognise that there will be some really big pressures over the winter months, and that's usually end of December going into January. What it will also do in the SEC, it's implemented another new national policy around how we measure the temperatures within our system. And we've worked very, very closely to get as much of this automated, so it's available to our whole system on an app so we can see. And that will also help our acute trusts to manage how they move some of their patients around some of the system. So all in all, if you were going to sum it up in a word, it is a coordination mechanism to manage the flow of patients where possible across our system and try to improve the outcomes for our population. And it's really focused around reducing those A&E waits and managing those ambulance response times as well. I think one thing it has done is it's been a mechanism to really bring us together to work really, really closely. And we've got quite a few new groups that have come out of it that are really working not only across our ICS, but across the wider ICSs within our region, because obviously our patients don't know boundaries. So I think it's been a really good mechanism for us to start to work together to look at and get that better coordination and get better outcomes for our populations. I don't know, Lou, if you want to add anything to that.
Thank you.
So does this feed into what you've termed proactive public-facing communications? I'm not quite sure what proactive public-facing communications actually means. Is it telling people don't go to this hospital if you're sick because it's already overflowing? Go to telling them to go to another one, or please stay at home,
or use your local pharmacist, or some of the medicines messaging. There's a whole communications plan behind it, but there are a number of different responses dependent upon the question, what the pressure is, and it's locally decided, because obviously each place will be experiencing slightly different pressures at different times.
And if I may just ask about the 10 high impact interventions, and 2 weeks ago in Health Service Journal it was told that there will be no central funding for the acute respiratory infection hubs. Does that mean that we won't have acute respiratory infection hubs this year, or are they going ahead but without central funding?
My understanding, yeah.
So we have a number of acute respiratory hubs across our places within the ICS. Fortunately, we did our planning early this year, and a number of them, not all of them, but a number of them were included within that capacity and that central operational funding that we get on a yearly basis. There are a couple of areas that are looking to fund them out of their core funding, but any of them that are happening within our ICS will not be through additional funding. They will be through existing funding that they had through either the operational planning or they ring-fenced for system pressures. But I can get you, I'm sorry, I don't know, but I can get you a definitive list of where they are, so that you can see which ones are actually going forward. But
thank you.
I think they were such a benefit from last winter that a couple of our places just kept them running all year round. So
Okay, thank you. Councillor Swift.
Yeah, still on 6.3, the where it says an integrated system response using the Opal framework, what does that consist of? Is it a group of people in some control centre in Newcastle who kind of click in at a certain time of day and work through the weekends and so forth, or is it a weekly meeting, or what exactly is it?
That's a really good question. Again, Deb's probably because you've been dealing with the Opal cards, but the Opal framework's been around for many years, but as part of the refreshment of the policies this year, a national product's come out, and it actually helps to give some consistency across different places and different trusts. And it is a set of actions that are locally done, locally initiated, based on the pressures that they're currently under. So Debs, do you want to just describe a little bit of where you might start with Opal 1 and move to Opal 4?
So the Opal framework has 4 levels, and at each level it's a measurement of pressure in the system, and that's calculated. It's a little bit complicated. It's calculated through 9 new national measures that are actually in the paper as well. At each level there is a list of actions that we would expect partners to take to manage the pressure in that system. So that's your coordinated proactive response, because you're looking at what your pressure is and you're looking at what you've agreed you will do when you actually hit that trigger. And that works its way through to an Opal 4, which obviously is where your system is under severe pressure, and we would start to look at additional measures that we would take across the ICS mutual aid between trusts and places. So it enables us and gives us a framework to go, it's getting a little bit difficult in 1. What are you doing to manage that? And then as you move through, do you need additional help from your partners across your system, but also across the ICS? So it just gives us the information to highlight where there are pressures and are there other things that we can start to do about that, so we can be proactive as well, instead of as much as possible, as well as being reactive as well.
It gives some very specific actions that a trust might take in conjunction with, say, the ambulance service, about how they might take patients into wards, etc. And if you would like the reading, then the Opal cards, if you open them up, become very self-explanatory. It's really difficult when we're trying to describe them in the abstract a little bit. The good thing is it's given some consistency, because you might have all been looking at it and going apples and apples, but they might have been Coxes and Brayburns. This year it's very much more apples and apples. So it's not a performance tool, it's a how's everybody doing, and can you give any support or take some ambulance diverts for a period of time to help us whilst we're struggling in one particular place. And that's really important. And we're talking with each of the trusts. In fact, they've set up a group, so they're talking to each other to say, well, how would we operate if this was happening? If we were at Opal 4 and you were at Opal 3, how could we help each other out? And it's really good prep work, but it's given us a level of consistency. Again, if you'd like a copy, it's something that we can give to you if you'd like that bit of extra reading.
Okay, thank you. Councillor Blackburn.
Thank you, Chair, and thank you, Lou and Deborah, for the comprehensive report. It's extremely useful. It gives me a lot of assurances that actually you are prepared as well as you can be. I think most importantly, my thoughts and thanks go to the workforce. It's a very challenging period of time. I think one thing that's probably is missing from the report, we're always shy away from it, I guess, in so many different levels, is that actually the number of people that are attending A&E that shouldn't be there. And actually, what are we doing to actually, start advert or give them something to say? Actually, next time, don't come and waste our time, because actually, this could be someone's life. I know that sounds really harsh, in terms of, because actually it's also the people that don't attend A&E because they feel as though, oh, I'm not that in such a bad condition. I seem to recall last year there were some adverts, some national adverts. I don't know if that's going to be the same, or there's certainly something on social media in relation to, informing people. But I think it just needs something extra. I get really fed up, and I feel it for the A&E staff, because actually half the people in there probably shouldn't be in there.
So some of that is in the comms plan, and there are some set pieces that are done each year, but they're used at certain points as well. So the timeliness, because if you just give one message the same for a number of weeks or months, people are blind to it, aren't they? So that it is sort of about how you pace that. In terms of avoidance for A&E, again, it's about promoting what the alternatives are. If you need, what is it you actually need, and where can you get it? So there is quite a bit of work on that. I'm sure there's more to do.
Thank you. Can I just ask about the high impact interventions? So I was reading this, and it's 10 high impact interventions, 3 or 4 priorities for impact this winter, 52 champions covering all 10 high interventions, and then the programme has been paused due to winter pressures. I thought this sounded really good. This sounded as if it could be really helpful for this winter, and then the programme has been paused. So are those 3 or 4 priorities that have the biggest impact, are they in place across West Yorkshire now?
Yeah. The 10, yeah.
Can you give a bit more information?
So the 10 high pack interventions are part of the urgent and emergency care recovery plan. And all places took a self-assessment to actually work out which ones that they thought they could have the biggest impact for winter, and they're the ones that they're working on through their champions. They are still committed to doing all 10, and we are just going through a process now to assess where, reassess and understand where they are as we move into the real winter period. The thing that's paused, and maybe I didn't make that clear, so sorry, is the champion programme. So we set the champion, that it's a national programme. So we set the champion programme up, but it was always due to pause over December and January, because most of the people that are involved with it are the people that are delivering the services on the ground. So it's a really core programme to get people that are delivering those services to work together to work out how they can improve those services. But obviously had to recognise that, because the urgent and emergency care recovery plan is a 2-year programme, they were really, really keen to say, we can't put additional pressure on these people, which is what Councillor Blackburn just said. They are the people that are delivering this. So it was a programme to support and help them, but also had to recognise that we couldn't expect them to commit 2 or 3 hours a week to something while they were delivering the busiest time for the NHS. Okay. But as we said, you can take the assurance that they are all working on their priorities, and over the next 2 years we will be monitoring their achievement of those whole 10 high impact interventions. It's a big word, that, isn't it?
Yeah, but thank you for that. Yes, thank you.
If you look at the UEC recovery programme slide, there is one attached towards the end. It's got a number of different portfolios that are being led by different SROs. There is all of the high impact interventions have got a home and a responsibility being led, and there is active work taking place, if that makes it clearer.
It makes sense, yeah. Councillor Rhodes.
Thank you, Chair. And yes, I think gratitude and applause to all those involved in trying to deal with the situations over the winter period. We had a presentation to the Wakefield Scrutiny Committee. Actually, it was our last committee. And very good presentation, but one of the questions that I've asked over the years and been made aware of through previous chief execs was the amount of beds, extra beds that were commissioned during the winter period. And over many years, there was information about 50 extra beds commissioned to deal with winter pressures. Now, I'm coming back to a comment that you made about Deborah, about the same thing, because we were told, obviously, that the beds were available within the trust, and they are still there. They're still there. my thoughts around that was, well, if they're still there and being used now because of extra demand, what happens if they're used by other demands and not available for the winter pressures that we seem to be ahead of being told by various people is going to be a poor winter? That's one point. And secondly, following on from my colleague about paragraph 6.3, about the coordination of systems and what have you. I mean, that is corporate working without silos, which should be happening anyway, and commends again for bringing that to the fore in terms of corporate working. One of the, let me see where it is now. We've had so many statistics today, and there's an expression, isn't there? There's statistics and damn statistics, but here we are getting a lot more of them, but well done anyway. In 6.4, it says the ICB is on track to achieve the 91% compliance against the 15, and you've just mentioned it, required operational standards for the SAC by the 1st of December 23. Well, lo and behold, that's next week, if we've got our dates right, because the way things are going. And I've gone through the report, and where could we find out more about the 15 operational standards?
Oh, shall we give you a copy
Can
of
send
them?
it to you.
Along with our compliance, because we're doing
this is
well.
where that's lovely, because this is where in our report, several, if you've been able to tune in, several have been saying, well, you know, there's this, that, and the other. Commendable, but questionable in terms of more information. And I think the operational standards in everything you've got in this report, all of it, really is the bedrock of what you do in terms of your workload for the winter pressures and throughout the year as well. And in terms of the 91% achievement, is this something that's a percentage that's set down either through your own regional efforts through Yorkshire and Humberside, or is it a national target?
It's national. There's a policy on what the system coordination centres have to deliver, and then they're tracking it through these metrics in terms of getting yourself ready. So we've been preparing. We're currently at 94% of achieving all the things that have to be done, and they're not easy things. There's some of it's about live data and digital platform. And we can pull the return out, and it'll tell you all the lines, that things you've got to get done, and it'll show you where we are on it, and we can add that to the bits on our hub and the other things that you've requested. But that one, it's been an extremely large amount of work to get to it, but we feel as though not only have we can tick the boxes, the more important thing is that we are working with our partners, so that we're saying, if we've got patient movement across boundaries, SCC in West Yorkshire, we're doing it this way. How are you doing it in South Yorkshire? What's happening between the boundaries as well? So we've really looked at it with a fine detail, but we can certainly provide that. That's not a problem. Gino Beds.
I think, Chair, that would be very useful, because when we're looking across boundaries with our partner organisations, and when you look at the southeast of the district in Wakefield, for instance, Barnsley is just across the border from, as you all know, from Wakefield. So it's important in terms of that work, that working together. And it's good to see in terms of the standards, what you've achieved. Now, I'm assuming again, Deborah and Lou, I'm assuming again that these standards, these operational standards here, they're a culmination of the reports you're getting from the other organisations, your partners working together with you. Because if you're achieving the 94, then that's great. Thank you very much for that. But you've mentioned other services like the ambulance service, etc., etc., etc. They will obviously have a knock-on effect if they're not reaching some of their targets. So is this a culmination of all partners, or is it just yourself delivering these standards?
So there's two lots of standards. The set of standards that you set at the System Coordination Centre to make sure that it's operating correctly, they're the same across the country. And when we look to our colleagues who are over the borders, because we share an ambulance service, don't we, across Yorkshire and Humber, they're working to the same standards to get their System Coordination Centre working and working to the same. And we're having quite a lot of detail in conversations to make sure it's not just we tick the box, but we actually know what we're all going to do and that it will work and run some scenarios through. In terms of system, service standards, we're constantly looking at those. The things that we are also looking at is the data, so we can look at the ambulances and how many are stacking outside certain hospitals. So part of the SCC's coordination role is to help with that, and so we do that on a hourly basis. We're constantly looking. There's someone always looking at it. So there's as I say, the standards for ticking off, have you got your SCC up and running properly? And then there's what's happening in the system. So what? You might be able to operate an SCC, but is it helping the coordination? And the answer to that is looking at the more live data that's happening day to day.
Okay, and last question, if I may, Chair. Where there is a blip or an emergency or a situation where you have to have that cross-boundary control, what measures and information are given to commissioners or providers of how and when to access that emergency role outside the authority?
Well, we've got a protocol for that, but I'll give that question to Deborah if you don't mind.
We've got lots of so when something happens, we've got lots of processes in place to ensure that we're able to manage that. Working through, and that's aligned to that Opal framework that we talked about. Right up until Opal 4, we would expect places to manage that themselves. We would participate and support, but we would hope that they've got the right command and control structures within their places, working across their system with all of their partners to manage their situation. And we would monitor their progress on that and their outcomes around that. It does happen, unfortunately, but at some point they may decide that that would take them into more of a critical incident. And that's where the ICS would start to invoke the emergency resilience and response preparedness, I should know,
okay.
response into that, which takes us to a whole new level of how we manage that situation. But I think it goes back to the question before, by having that Opal framework, we're able to be a little bit more proactive. So when we get to Opal 4, we would probably, me and Lou would be answering the question, what is the likelihood over the next couple of hours that we might be getting to a critical incident? And we would be able to assess and put a lot more in place because we've monitored the progress of the pressure as it moves up. But it isn't in the paper all around the emergency resilience and response, but we work very, very closely, and the SRO for the SCC is our emergency accountable officer, who's accountable for the EPRR as well. So those two at that point virtually become, integrated, and we would manage response in that way. But we can send you the document around the Opal framework, and it's very, very clear about that change between Opal and then when you go into a critical incident. So I think that should give you that level of assurance that we've got as you.
We've just done a tabletop exercise where regional colleagues have taken us through our paces to go
and out of ours.
If this scenario happens, what the response? What's the governance? Who would be involved? How to get clinical input? So we've just been testing out our plans, if that gives any assurance. Unfortunately, some of the scenarios we've already faced in the past, so we did know what to do because it was a bad winter last year. But just to give you that reassurance that these aren't just pieces of paper, we are practicing.
Okay, thank you very much. Thank you.
Thank you so much. Thank you.
Is that okay, Councillor Rhodes?
Thank you.
So I think if we bring this to a conclusion, then so our thanks to everybody working so hard over this winter. I think throughout the year. You're going to send us some Opal information. I think if there is updates presumably local place scrutiny boards get updates from their trusts individually on where they are with pressures during the winter. But if you could send us the Opal information, if you could also send us the list of centres that Councillor Hutchinson was asking about, and you also said you'd send us the operational standards information that Councillor Rhodes was asking about. If you could email those through, please, to the officers supporting this panel, that would be helpful, and then we can send them all out together to colleagues, so that we're not waiting for the next meeting to do that. The information it comes sooner than that to everybody. Can I thank everybody today for attending the meeting, for a really good discussion on all the items. Thank you so much, and we will have our next meeting in January. Thank you.
Thank you very much.
Thank
Thank
you,
you.
Chair.
Bye. Bye.
Thank you,
Thank you,
ladies.
Chair.
Thanks.
And everybody.
Thanks.